Professor Foud Fayad is a distinguished rheumatologist, educator, and researcher. He heads the Rheumatology Department at the Lebanese University Faculty of Medical Sciences and the Rheumatology Division at Lebanese Hospital Gaitawi, University Medical Center. He is also a professor of clinical medicine at the Lebanese American University Medical Center, a fellow of the Royal College of Physicians in Glasgow, and a board member of the French Society of Rheumatology. With over 120 publications, Professor Fayad advances rheumatology through research, leadership, and precision medicine, tailoring treatments to patient-specific disease mechanisms. His work bridges clinical experience and academic excellence, reshaping standards of care and contributing significantly to the field both in Lebanon and internationally.
It's a pleasure to introduce Dr. Foud Fayad, who's
Uh,
going to talk about the multidisciplinary approach in chronic pain management in 2025. Dr. Fayad, the floor is yours.
Thank you. Good afternoon. First, I would like to thank you for your kind invitation for this excellent meeting. I'm so proud to be one of the physicians in the Lebanese Order of Physicians, Tripoli, Lebanon. So when I discussed with Dr. Lina Rafi about the potential conferences, topics, so she told me إنه بدنا نحكي عن multidisciplinary يعني الهوليستيك approach in chronic pain. قلت لها تكرم عينك رح نحكي عن هالموضوع. So as a rheumatologist, we are facing a lot of patients suffering from musculoskeletal disorders. Also, we know very well that musculoskeletal disorders rank actually second in the global disability burden. First, هن المود disorders. Musculoskeletal actually rank number 2. 30% of disability is related to our diseases in the musculoskeletal system. And they contribute significantly to years lived with disability. وهذه معروف اليوم بال WHO WYLDS. And osteoarthritis and low back pain are primary contributors to disability adjusted life years. And the economic impact is very, very high. First, because of the direct cost, depending on the disease itself, but also indirect cost with the loss of productivity and long-term disability. ونعرف إنه بالبلدان industrial countries بيدفعوا للبيشنت اللي عندهم disabilities وهانديكاب يلي هو للأسف منه حاصل عنا بلبنان بسبب المشاكل الاقتصادية. And we are facing an increasing survival rate and aging population and sedentarity, and I will add also obesity. ونعرف اليوم إن obesity worldwide is exponentially increasing, and they are directly correlated with these problems. And all these increase the chronic musculoskeletal pain problems, prevalence, and highlighting the need for effective multidisciplinary management team strategies. So this CMP affects over 11% of the global population, resulting in significant physical, psychological, and socio-economic burdens. And the common conditions are osteoarthritis, rheumatoid arthritis, 1% of the population, and we did a study not published in Lebanon in the Tertiary Care Center. We saw also that spondyloarthropathies are 1.4-fold the prevalence of rheumatoid arthritis, fibromyalgia, very common disease, and chronic low back pain. And due to its complex biopsychosocial nature, chronic musculoskeletal pain requires a comprehensive, multidisciplinary treatment approach. What is the definition of chronic pain? We actually agree, and the International Assessment Society of Pain said we should talk about chronic pain when we have pain persisting over than 3 months. which is considered the time for normal tissue healing. It involves persistent nociceptive input, central sensitization, nociplastic mechanism causing not only pain, but also stiffness, fatigue, and functional impairment. And they are frequently associated with comorbidities, especially depression, anxiety, and sleep disorders, which worsen outcomes. And by the end, they are affecting significantly the quality of life and increase healthcare utilization and disability. How many types of pain do we have? Classically, we said that we have the nociceptive pain related to a direct injury, inflammation of the tissue. Could be the skin, could be the joint, could be the spine, etc. And the neuropathic pain when we have a damage of the nerve. But recently, the international expert and the Pain Society globally are actually in according to say that we need to have a new definition for the nociplastic pain, which is a semantic term suggested by this expert to describe a third category of pain syndromes of undetermined etiology. And the nociplastic pain can occur in isolation, most commonly in fibromyalgia, for example, but also in a mixed pattern of pain, combining the nociceptive, the neuropathic, and the nociplastic. And the best example here is the chronic low back pain when we have these three entities of pain. And in addition to this, the symptoms observed in nociplastic pain include a pattern of pain, which is a multifocal pain, more widespread, more intense, or combined, in addition to other CNS derived symptoms such as fatigue, sleep disturbance, memory loss, and mood problems. And when we are talking about chronic pain, we should talk a little bit about this complex pathophysiological problem, how these patients develop chronic pain. From an injury, a small injury, they go into a chronic disease. It involves a lot of things, and we know very well the importance of nociceptors, the maladaptive plasticity in the spinal cord and brain, the neuroimmune interaction that perpetuate pain signaling, and altered pain processing pathways. Unlike acute pain, chronic pain involves persistent change in the nervous system at multiple levels, peripheral, spinal, and central. First, the peripheral sensitization. And here we have what we call the inflammatory soup. So after an injury, a lot of inflammatory cytokines, mediators, are released at the site of the injury, forming an inflammatory soup. These mediators lower the activation threshold of nociceptors and the fibers A and C fibers, leading to increased firing and heightening pain intensity. And we talk here about hyperalgia and allodynia. And persistent peripheral input maintains abdominal pain signaling and can drive central change. For the central sensitization, first at the level of a spinal cord, we have here an increased excitability of the dorsal horn neurons of the spinal cord due to repeated input from sensitized nociceptors, and also reduced inhibitory neurotransmission, for example, the GABA, the glycine, enhancing pain transmission. So من أول فلو نيرفير اللي طالع على الراس تيقول إنه في مشكل ومنمنع الانهبيتوري باثواي يلي بيمنع إنه يطلع هالانفلو بشكل قوي على الدماغ. So here we have the first problem for the central sensitization. And the second one in the brain, and here we have the confirmation thanks to the functional MRI In the brain, we have an amplification phenomenon of pain signal. يعني أنا عم وشوش حاطط ميكروفون عم بسمع الصوت كتير قوي. مش لأنه صوتي عالي لأنه في amplification phenomenon of pain signals in area like the anterior cingulate cortex and insula, and also a disrupted descending inhibitory pathway. By the end, we have a widespread pain, sensory amplification, and pain from normally non-painful stimuli. And finally, we should not forget the neuroimmune interaction. Here, the cytokines and other neurotropic factors interact at all these levels to increase the problem of hyperexcitability and the sensation of pain. Also, these neuroimmune crosstalks perpetuate inflammation and abnormal pain signaling. يعني الليمفوسايت T والليمفوسايت B بيلعبوا دور بالchronic pain. And finally, neuroplasticity. So long-term potentiation in pain pathways leads to persistent change in synaptic strength and pain perception. In summary, chronic pain is maintained by a self-reinforcing loop, cercle vicieux, of peripheral and central sensitization, neuroimmune activation, and maladaptive neuroplasticity. We talked about the biological process of chronic pain, but we should not forget that chronic pain is not only related to biology, but also, and since 1977, we have also the psychological point, which is very important in chronicity of pain, and the social also dimension, and all these three parameters are very important to well know to guide the multidisciplinary teams for intervention, targeting pain modulation, functional restoration, and psychosocial resilience. And here we go for the multidisciplinary approach for the management of chronic pain, and we have the conceptual framework, including all these actors in the field of health to help patients in overcoming the problem of chronic pain and related comorbidities and related disabilities and a handicap. And the core components, we have a comprehensive biopsychosocial assessment, individualized evidence-based multimodal treatment plans, coordinated interprofessional communication and patient engagement, and focus on functional recovery and restoration of quality of life of these patients. Here are the main actors in this multidisciplinary team, and I will go for each of these actors. The primary care physician, family practice, rheumatologist, so orthopedic surgeon, neurologist, all these physicians should work for early identification and risk stratification of chronic musculoskeletal pain patients. Second, they should also do a workup, a detailed workup to exclude serious pathology and the red flags. For example, in fibromyalgia, we should be able to say that we should not have other diseases that can mimic the symptoms of fibromyalgia. And for each disease also, we should have our workup to say, yes, it is only a chronic musculoskeletal pain and not another organic disease. Also, the primary care physician should initiate a conservative management, combining education, analgesics, lifestyle advice, coordinate the referrals to MDT members and provide ongoing longitudinal care, and foster patient-centered care and shared decision-making. The specialist also should go deeply in the management of these patients with a more detailed and deep clinical exam using advanced technology and imaging and electromyography analysis, etc., to phenotype the pain mechanism. And they have an arsenal of medications starting from the classical NSAIDs. They work very well in inflammatory type of pain, not in all pain, and respecting the potential contraindication in these patients. The antidepressant, and actually we have the FDA approval for duloxetine, but we know very well this molecule amitriptyline, بلبنان اسمها تريبتيزول, بفرنسا بأوروبا اسمها لوروكسيل, etc., which is very effective in management of the chronic pain. And for the neuropathic and nociplastic type of pain, the anticonvulsive اللي هن الجابابنتين, البريجابالين عنده FDA, for example, بالfibromyalgia, modulate neuropathic pathways. Opioids, unfortunately, وهذا المشكل الكبير, in these chronic patients, we have a lot who are on opioids, and we know very well the risk of opioids and the dependence on opioids. So we'll see the effect of MDT in the decreasing the rate of patients on opioids. And we have emerging agents such as NGF antibodies and cannabinoids, but these new molecules require further validation. We should not forget the interventional procedures, for example, the epidural injection of steroids, the radiofrequency ablation, etc. So here, the pain specialist domain. We should not forget the physical therapist with the development of individualized exercise programs for these patients, manual therapy and electrotherapy modalities, and ergonomic education for functional restoration strategies. And it should support also the gradual activity pacing to prevent flare-ups and promote adherence. And here we have a lot of programs for rehabilitation. Here I put the example for the Japan's multidisciplinary pain rehabilitation program, but also we have a lot in Europe and the States. And all these programs aimed to reintegrate patient in a functional activity and to improve the quality of life and restore the function. Also, the dimension, the psychological dimension, with psychologists and psychiatrists should work on cognitive behavior therapy, on mindfulness-based stress reduction. We should decrease the catastrophizing phenomenon and the fear avoidance in these patients. And also, we should not forget to manage the comorbid mood disorders such as depression and anxiety. For the non-pharmacological intervention, we have a lot of options with a different level of evidence according to the studies. We have the acupuncture, the biofeedback, manual therapy, mind-body therapies, etc., and finally the multi-component approaches. The best way is to work together and to adopt the multimodal analgesia, combining pharmacological and non-pharmacological treatments to optimize the analgesic effect of in our patients. And also, we should not forget that we are treating a patient, not a disease, so we should work and focus on the patient and tailor the intervention according to individual values, preferences, and goals. Use your shared decision-making with the patient, and here we should give time in our consultation for our patient, not at 10 minutes, not in 20 minutes, not in 30 minutes, we can manage these patients. And we should provide culturally sensitive care and address psychosocial determinants and use the patient-reported outcome measures. مش بيكفي أن الطبيب يكون satisfied. لازم يكون المريض satisfied, and we should work at satisfying the patient-reported outcome measures to guide our management and treatments. We should not forget patient education and self-management. Empower our patient to face their problem and teach them for self-management strategies, for relaxation, for lifestyle modification, for weight loss, smoking cessation, and strengthening therapeutic alliance and promote resilience. What do we know about the benefit of this multidisciplinary management in this chronic musculoskeletal pain? So we know very well, according to different studies and evidence-based studies, that MDT improves physical function, reduce psychological distress, and enhance quality of life. And for the cost effectiveness, it decreases the health cost by preventing unnecessary investigations. بنشوف المريض عنده أوقات 5 و10 MRI وCT سكان و3 4 AMG و20,000 فحص دم. بيكفي كان يكون في عنده consultation مع مالتي ديسيبلينري تيم تيقتنع ويطمئن انه هذه هي مشكلته ما في شيء زياده، ونكتفي بهالفحوصات المعموله. اذا في شيء ناقص نكمله، مش نرجع نعيد كل مره. So we can decrease the cost due to this multidisciplinary management, accelerate recovery, and improve patient satisfaction across diverse musculoskeletal pain populations. Supported data by meta-analysis shows that we can decrease up to 30% the opioid use. مريض على 3 بيوقفوا المورفين وشوابه المورفين. And better functional outcomes with MDTs. Sure, we have challenges to overcome in the implementation of MDT. First, limited availability, communication gaps between among professionals, the workforce shortages and insufficiency for multidisciplinary training, cultural and systemic factors affecting patient engagement. And we have proposed here many solutions, such as, for example, telehealth expansion, policy advocacy and training programs. Preventive strategy, الوقاية خير من قنطار علاج. So we should identify early patients at risk for chronicity. وهيدي عملنا دراسة وقت كنت بكوشان بباريس عن risk factors to go into chronic low back pain in patients suffering from early low back pain. ولقينا انه في كثير اشياء والدايمنشن psychosocial اهم بعد من الاورجانيسيتي. والساتسفاكشن بالورك والانكزايتي والديبريشن اهم من اذا الارنيا كبيره او عنده ارتروز على 3 ليفل او على 5 ليفل او على ليفل 1. Very important. So in other diseases, we should work for early identification of these risk factors to prevent the chronicity. We should work on lifestyle modifications, on workplace ergonomics, and public health campaigns to raise awareness and promote prevention. We can use the technology in our multidisciplinary management.
Dr. Fayad, excuse me, you have 2 minutes remaining.
Okay. Telemedicine, digital platforms, wearable sensors, integrated electronic health records, and we have emerging tools such as AI-driven analytics and others. Global perspective, MDT availability varies globally, more established in high-income countries. بتتكلف تقدر تحط هيك سيستم. International Assessment Society of Pain and WHO advocate MDT as standard care, but the problem still persists in low and middle income countries. For global collaboration, capacity building and policy support are essential to expand MDT access. We have some ethical considerations we are showing here. Future direction, emerging therapies go deeply into gene editing, stem cell therapy, AI-driven predictive analytics, modulation of peripheral and central sensitization with specific drugs, neuromodulation. Here we are using these techniques for refractory cases, such as, for example, spinal cord stimulation or peripheral nerve stimulation, virtual reality and digital therapeutics, precision medicine integration to optimize individualized treatment plans. For the research priorities and the frontiers of these MDTs, we don't know actually the long-term MDT cost effectiveness. We know it at short-term, middle-term. Biomarkers development for personalized pain phenotyping, understanding individual molecular and cellular drivers for chronic pain for personalized treatment, and ongoing development of closed-loop neuromodulation and targeted biologics. In conclusion, chronic musculoskeletal pain is a complex, multifactorial condition requiring holistic management. Actually, MDT approach represents the gold standard for management of these CMP. MDT integrates diverse expertise addressing biological, psychosocial, and social and psychological dimensions. There is strong evidence supporting MDTs in improving outcomes and decreasing the opioid reliance. We should work on the patient-centered care, and technological integration are vital for future advances. Content innovation, research, and policy support are imperative to expand access and optimize care delivery worldwide. Thank you.